All right, good morning, guys. It's 9 o'clock. RT 210C's exam, pulmonary A and P, is now complete. For the most part, we had a very good showing this time. You're getting stronger. If you didn't do as well as you thought you wanted to do, don't give up. You still got a lot of ways to go, okay? If you have whatever study habits you're using, you need to try to switch them up and come to tutoring on Tuesdays and Thursdays if you're having a problem, and we can specifically work on whatever you're having a problem with or to help you study for the exams, okay? But we got to keep going. We are now in pulmonary mechanics, and to this point, we've learned some important terminology as far as respiratory is concerned. We've learned the heart and how it functions, whether on a physical level, on the cellular level, right? And on the electrical level. And we know the blood flow through the heart. We learned the electrical conductivity of the heart, purpose of the blood, and why it's so important. And then we moved on to the lungs, pulmonary A and P, starting from the nose all the way down into the land of the parenchyma. And what is the function of the lungs' primary job, which is external respiration, right? All right. Now, we're now going into pulmonary mechanics, which talks about the compliance of the lungs. And we kind of hinted at compliance the other day when we talked about how much a lung can stretch or not stretch, and how surfactant can play a part in the lungs' compliance or flexibility, right? Also, we're going to learn about the volumes that go in and out the lungs. Not only just what it is, which is oxygen or CO2, but how much of it is actually moving in the lungs with each breath or per minute, okay? So you're going to learn some different formulas in this lesson. You're going to learn minute ventilation. You're going to learn the formula for compliance, static compliance, dynamic compliance, alveolar volume, alveolar minute ventilation, right? The formula to find average tidal volume, which we kind of played with that a little earlier, but I told you when you get to the section where we really are going to talk about it. How to find that tidal volume. Also, how to find the dead space. We talked about anywhere in the lungs that is a conducting zone is called dead space, right? That gas is not participating in gas exchange. So any gas that's not participating in gas exchange, that's dead space gas, right? Or dead space volume, all of that. And so we have different types of dead space, right? And you're going to learn the different types as well, okay? So this is going to get a little more involved. We're also going to learn about the spirogram back here. The lungs have 4 volumes and 4 capacities. And you'll need to know how to demonstrate those volumes and those capacities. Very important. All right, so I'm going to pull up the lesson plan. Pulmonary mechanics. Again, if you did not pass this exam, make sure you do the practice and review that I'll open up at the end of the session today. Go to that failed exam module, and you'll see pulmonary A and P. It'll be open. Complete that one just like you did the last one. Right, but that'll be open at the end of class. All right, so here we go. I'm sharing my screen with the lesson plan for pulmonary mechanics. All right, some of the main objectives for it will, student will be able to given information, calculate the static and dynamic compliance, discuss the changes in compliance, discuss changes in resistance, describe the series of events in ventilation, differentiate between ventilation and respiration. We talked about that last time. I said ventilation is when you move the gas in and out, right? That's just the art of moving gas in and out of the lungs. But respiration is when the gas actually exchanges. Okay, that's respiration. And then you have internal respiration and external. External is the gas exchange in the alveoli between outside air. And internal respiration was when the gas exchanges at the tissue level. Okay, so that's different from ventilation. Now, also, recall Pulmonary and Laplace's law and their importance. Talk about the law of Laplace. The law of Laplace. We haven't gotten to gas laws yet, but law of Laplace talks about the raindrop. It says that because of the surface tension, the larger sphere or the larger raindrop will suck in the smaller one. Okay, we talked about that. And so that's the law of Laplace. That's his law. He says that that will happen in physics. But because of surfactant we can defy that law. And small alveoli can sit and talk and communicate with larger alveoli without the fear of collapse, okay, because of surfactant. Pulmonary, you're going to learn who he talks about resistance. He'll talk about resistance. He says that if I decrease the diameter of a hole by 1/2, I will increase the resistance by 16 times. Okay? Pulmonary's law says if I decrease the diameter of a vessel, right? Whatever it is, water hose, whatever it is, if I decrease it by 1/2, then I will increase the resistance inside of there by 16 times. Okay? So that's kind of like putting your finger over a water hose, right? You are decreasing the diameter of the water hose. And what happens when you do that? So it comes out fast or slow? Fast, right? When you put your thumb over half of it, it's going to start shooting out, right? Because you have increased the resistance by 16 times, okay? So that's physics. Same thing will apply to your lungs. If your bronchioles and your large airways are decreased by 1/2 because of a tumor or secretions, then the resistance inside of there will increase. And not only will the resistance increase, but your work of breathing will increase, right? If I cover up half of your trach, it's going to be harder for you to breathe, like breathing through a straw. So your work is going to increase. All right? You're going to be able to draw the spirogram. That's what's on the board, that spirogram, by heart, labeling the 4 volumes, 4 capacities, and their normal values. Describe each volume or capacity as a function of inspiration and expiration. Discuss the relationship between the FRC and compliance. They go hand in hand. Okay, if you have an increase in compliance, you have an increase in FRC. A decrease in compliance, you will have a decrease in FRC. They are directly related. FRC and compliance are directly related. Okay? All right. Calculate minute ventilation and alveolar minute ventilation. Describe dead space and what's the normal value for dead space. Describe the equipment used to measure tidal volume. Describe eucapnia. Eucapnia is a normal what? No, eupnea is normal breathing. What would eucapnia be? Normal what? Kinda, but what am I looking for? What's capnia? Capnia is ventilation, but what is it? What is the gas? CO2. Remember capnia and carbia? So eucapnia is normal CO2 level. Okay? So describe normal CO2 ventilation, hypoventilation, hyperventilation, right? Same thing as say a hypocapnia or hypercapnia, okay? All those are the same. In view of alveolar ventilation and dead space. Then you're going to describe the normal unit, dead space unit, shunting unit, and solid unit in terms of perfusion and ventilation. Remember, I showed you that on the board. We're going to learn it in depth today, in this section. Explain the RQ, which is the respiratory quotient. Describe regional differences of the VQ, which is ventilation to perfusion. VQ is ventilation to perfusion. It's called the VQ ratio. Okay. You'll be understanding the difference between the VQ ratio in sitting, or reclining and sitting. Differentiate between shunting and dead space. You got to know the difference between those. And discuss causes of shunting and the dead space. And describe the types of dead space and the 4 types of shunting. All right, let's have a 75 to pass this exam. All right, here we go. Ventilation, mechanics of ventilation. We talked about ventilation and respiration. We said those 2 different things. Ventilation is the air moving in and out the lungs, okay? And that allows for the respiration. But respiration is gas exchange across a permeable cellular membrane. What cellular membrane of the alveoli is gas permeating? What type of cell? Which cell is the gas permeating? Type 2 cells make surfactant. There you go. Type 1 cell. So respiration, the external respiration, is gas exchange across the type 1 cell of the alveoli, right? And the capillary. They are going, the gas is diffusing in and out. That's what permeable means. It's able to get through. All right. Now, external respiration, as we said, is gas exchange between the alveolar gas, which is the air, and the capillary, which is the blood. Okay. Internal respiration is gas exchange between the capillary and the tissue level. Then we're going to talk about laminar or turbulent flows. The flow that goes through the respiratory tract. As the air travels through the respiratory tract, it's either turbulent or laminar, okay? And sometimes it's mixed. But these have special notoriety. The laminar or turbulent flow is determined by the Reynolds number. You won't have to know how the formula for Reynolds number, but if I give you a Reynolds number, you need to be able to tell me, does that mean that the gas is going through nice and easy and smooth, or is it turbulent? Okay. A Reynolds number less than 2,000 is laminar. That means smooth. Smooth. Laminar is smooth. Less than 2,000. So if I said, we did the Reynolds number, and he has a Reynolds number of 1,000. Well, then I know that his flow is laminar or smooth. Okay. 2,000 to 4,000 is laminar and turbulent or mixed flow. And a Reynolds number greater than 4,000 is turbulent, right, or rough. Same thing as a plane. When a plane is traveling through the clouds, if the air is circling in several different directions, it's going to shake the plane in several different ways. And they call that turbulence, when we hit a pocket of turbulence. Well, when the air is going through the lungs, depending on the resistance, depending on what's in there, like secretions or whatever's going on, if that air starts to swirl up and turn in different directions, it becomes turbulent, okay? Or when it changes direction. When the air comes down the trachea and turns to the left and right main stem bronchus, at the turn, there's a little bit of turbulation, right? Because it's got to change. It changes direction, so it'll kind of spin around a little bit, okay? It's not that important as far as what we know. Just need to know the Reynolds number. Less than 2,000 is laminar. Greater than 4,000 is turbulent. 2,000 to 4,000 is mixed. All right, the lung-thorax relationship. We learned that the diaphragm, when it is stimulated by the what nerve? The phrenic nerve, it will descend. It will flatten, right? It will contract. And when that happens, it sucks the lungs open like a vacuum. And that interpleural pressure becomes more negative, okay? It's a negative force, all right? And that force will become more negative than the outside or ambient air, which will automatically make air come in, okay? So the two opposing forces are the lungs tend to collapse due to elasticity, right? After you inhale and let go, they want to collapse, right? Because they're elastic. But because the chest wall and the interpleural pressure are equal, that keeps the lungs open. Okay, if I was to put a hole in my side, my lung would shrivel because now I don't have that opposing force. The chest wall wants to keep them open. The lungs want to collapse. So they stay right where they need to be, okay? The chest wall wants to spring out. So that will keep the lungs open, but the lungs want to shrink in because they're elastic, right? And so because of that, they're opposing each other, which keeps the lungs open at all times, okay? Keeps the lungs open at rest, all right? Thank God for that. Because if we had a hole in my side, the air from my lung would then be coming out and my lung would just shrivel up, okay, because it's so elastic. So they're linked together by the pleura, right? You got the visceral pleura and the parietal pleura. That's what's linking those, the chest and the lungs together. Now, negative pressure, -4 to -5 centimeters of water, okay? It has a negative pressure of -4 to -5 centimeters of water. The parietal pleural, which lines the chest wall, right? The visceral pleural covers the what? The lung. Now, there's a potential space between them with a small amount of lubricant or pleural fluid between the layers. What's that fluid called? Serous fluid. That because since the lungs, the chest wants to do one thing, the lungs want to do another thing. It's kind of like, like suction, right? And so it's pulling and it's pulling, so it keeps it open. All right. And that fluid is in there for when you inhale and exhale and you're not rubbing together, causing friction. Okay. Now, normal ventilation pressures. On inspiration, the intrapleural pressure is about -9 centimeters of water. And the intrapulmonary pressure is about -3 centimeters of water. On inspiration, when you take a breath in, your intrapleural, so the pressure in the pleural space is about -9, and the intrapulmonary, which is inside the lungs, is -3. So because it's more negative than outside, air has no choice but to suck in, okay? And so during that inspiration, the diaphragm is contracting or flattening, right? The chest cavity expands, right? The AP diameter of the thorax increases, right? The negative you have a negative intrapulmonary pressure and a negative trans airway pressure. So what happens? Gas flows what? In through the mouth. So when you take a breath in, you are becoming more negative. The diaphragm is doing his job, right? Descending, making the intrapulmonary pressure more negative than outside, and the air just says, shoo, because air and fluid follow the path of least what? Resistance. So whichever has a smaller the diaphragm does its job by making the intrapulmonary pressure become more negative than outside, basically, okay? And when that happens, gas has to go in. Now, what happens when we exhale? During expiration, the diaphragm will relax, right? And look at the intrapulmonary pressure then, +3, it becomes positive. So the intrapulmonary pressure on expiration becomes positive. Intrapulmonary, inside the lungs. It becomes positive, which makes it higher than outside, okay? And so if it's higher than outside, that means air has to run away from my lungs and go out, okay? Because it's running away from the pressure, the higher pressure. So what's happening during expiration? The diaphragm relaxes, the chest cavity recoils and decreases in size. You have a slight positive intrapulmonary pressure, and gas flows out of the mouth. Okay, that's the basics of the physics that's happening in your lungs. Now, the intrapleural pressure always stays negative. It's always slightly negative. More when you inspire than exhale, but it's always slightly negative. The intrapulmonary pressure is what changes and makes the gas move. Okay, intrapulmonary, that's the pressure inside the lungs. Intrapleural is the pressure in the pleural space between the pleural. Everybody understand that? Okay. Now, physics of ventilation. This is the law of Laplace. Law of Laplace. P equals 4st over r. Don't have to remember that formula. Just need to know the law of Laplace says surface tension tends to collapse alveoli because of surface tension. If you have a big alveoli next to a small alveoli, it's going to suck it shut if you don't have surfactant. Surfactant allows different size alveoli to be connected without smaller one emptying into the larger one and collapsing. What we've already talked about. What is surfactant? It is a phospholipid. It decreases the surface tension of the alveoli and allows critical volume to be variable from alveoli to alveoli. Now, critical volume, everybody listen. The critical volume is the volume at which the alveoli can stay open. If the volume falls below critical volume, the alveoli closes, okay? So it's kind of like saying your breaking point. You know, I'll do this until you get to this. When you do this, I'm done, right? So the critical volume is something like that. It's the amount of volume that must be there to keep it open. The last little bit, if it drops below that, it closes, okay? And so surfactant allows different critical volumes because a bigger one would have more critical volume, right? You have bigger alveoli than others. They are not all the same size. But because of surfactant, it allows them to coexist or having different critical volumes. It doesn't matter because the surface tension is so low, right? And because it's so low, it keeps it from collapsing. So that's the magic of surfactant. We also said it's continuously continuously produced, secreted, and eliminated, right? Detergent-like fossil is a very magical substance made by the body, made by the what? Who makes surfactant? The Clara cells, type 2 alveoli cells, they make the surfactant of the body. Now, if we don't have that, when you have a baby who was born premature, they have not developed all of their type 2 cells well. So their Clara cells are not performing well, they're not secreting enough surfactant. So when they come out, it's hard for them to breathe. It's like a dry sponge, right? It won't come out. So we have to insert surfactant called Survanta into the baby's lungs before he's born, okay? Sometimes we have to put a tube into the vagina, into the baby's throat, and either suck out meconium, right, which is a bowel movement from the mother, or insert surfactant. And that way his lungs get loose for when he comes out to take that breath, because when he takes out, he's been breathing amniotic fluid all of that time, right? The baby's been breathing fluid. Now he got to transition from fluid to air. But if the surfactant is not on deck, then the lungs are going to be like a dry sponge. So we have to inject, and we as respiratory would inject surfactant into the baby's lungs and maybe do a little bagging. And then when he come out, he can cry, right? And so that's one of the problems with premature, okay, when they come too soon. Lungs are not fully developed. All right, compliance. Compliance is a very important aspect of respiratory. Got to be able to understand compliance. Simply, compliance measures the distability of the lungs. How well can it stretch? Is it a dry sponge or is it a wet sponge, right? If we take a wet sponge and squeeze it, it'll open right back up with no problem, right? Squeeze it, opens up with no problem. But a dry sponge is hard to even squeeze. It won't do anything because it's dry, right? So compliance is what the measure of that is. It also, if you think about compliance, you must think about it, or to help you remember compliance, is thinking about a child. If a child will do whatever you tell him to do, then he has a high compliance. He's compliant. He'll do whatever you want him to do. If he has a low compliance, he won't do what you tell him to do, right? He has a low compliance. People who are supposed to take certain medication regimens when they're at home, they ask them, are you compliant with your meds, right? That means I'm taking them every day. I'm taking them on time. If I don't ever take them, I'm not compliant or non-compliant. I won't do what you want them to do. So simply the compliance means, will the lungs do what you want them to do or not? If they won't do it, it has a low compliance. If they'll do whatever you want them to do, they have a high compliance. Okay? COPD patients have floppy lungs, right? They have lost their elasticity because of smoking. That's why they can't get the air out, right? We said COPD patients is a chronic obstructive problem. That means they can't exhale well like we can, right? And since they can't exhale well, they start to build up what? CO2. So they always have a higher CO2, right? They're always hypercapnic, okay? Always, because they can't get all of the CO2 out because the lungs are just floppy, like old drawers, right? You take the old drawers out the drawer and they just hang there, right? Don't have no snapback anymore, okay? Or some old socks that when you put them on, they don't even touch your legs no more, right? They have lost their elasticity, okay? So they have a high compliance. I stretch them as far as I want to stretch them, but they'll do whatever I want them to do. You know what I'm saying? Because they're so floppy. So COPD is directly related with a high compliance, okay? High compliance. Let me put this. Write this down. It's another one of those, not AKAs, but one of these relationships you need to understand. One of those relationships you need to understand. Increase in compliance equals COPD, okay? And then if also increased compliance equals an increase in FRC. If these statements are true, then what is the mathematical statement I can make about COPD and FRC? If a high compliance is COPD and a high compliance is increased FRC, then what statement can I make about COPD and FRC? COPD equals what? What type of FRC? High FRC. Right? If a high compliance, if a COPD patient has high compliance, every COPD patient has a high compliance. And I know that a high compliance is synonymous with a high FRC. Well, that means every COPD patient gonna have a high FRC. Okay? Not only that, but let's look at this part. Decrease in elastance. I feel elastance. S-T-I-N-C-E, elastance. T-E, okay. All right. Decrease in elastance equals COPD. All right. Because they have lost their what? Elasticity. So a decrease in elastance will equal COPD. Right? So I can make another statement. So I can make a statement about compliance, COPD, FRC, and elastance. One statement. What statement would that be? If I make it right here, what statement would that be? Knowing what you know. A high compliance is COPD. A A high compliance is high FRC, and a decrease in elastance equals COPD. So what else can I say? What's the whole thing I can say? Okay, COPD equals what? Okay, a decrease in elastance. And what else? A what? An increase in FRC. And a what? And an increase in compliance. So a COPD patient will have a decreased elasticity, they will have a high FRC and a high compliance. Because high compliance means you'll do whatever I tell you to do. The lungs will stretch as far as I want. They're just like floppy socks, right? Floppy lung. Emphysema is another word for floppy lung. And emphysema is one of the COPD diseases. Right? All right. So there's different types of compliance. Got a couple of different types of compliances. And you're going to understand when we get to the spirogram, you'll understand the FRC. But I want you to be thinking about that COPD can't get the air out, so they have a high FRC. So FRC, where is that at on the breathing pattern, right? We're going to learn that next. I'm going to get that out the way because it comes a little bit later, but I like to get the big stuff out the way. Like when we do pharmacology, I'm going to do my magic drug calculation stuff first and get that out of the way before we do anything else. Okay, which is a trick. I got a trick for it. It's going to be very easy. Work smart, not hard. All right. Compliance. Compliance is, the formula will be the change in volume divided by a change in pressure. Compliance equals a change in volume, that little triangle means change. Change in the volume over a change in pressure, because that's how we measure the compliance of somebody. If they're on a machine or ventilator and their volumes are changing and the pressures are changing, then that means their compliance is changing, okay? For instance, if it was taking me 25 centimeters of water to push in 500 tidal volume, right? I push in 500 tidal volume into your lungs and it takes about 25 centimeters of water of pressure, okay, to do it. Well, then a little bit later, I'm noticing that I'm only pushing in 450 volume now, and the pressure has increased to 35 centimeters of water, okay? That has been a change in pressure, a change in volume and a change in pressure, okay? That lets me know that, hey, his compliance is changing, okay? If it's taking me more pressure to get the same amount in there, then his compliance is going down. It's not doing what I wanted to do, it's tightening up, okay? If I'm putting 500 and it was taking 25 centimeters of water of pressure, and now that same 500 is only taking 15 to push in there, then his lungs are getting more stretchy, right? The compliance is going up, okay? You have to understand compliance. All right, so this is something we'll go over this part really quick, but total compliance of the lung and the thorax. Pulmonary compliance is about 0.2 liters per centimeters of water, which is 200 mLs, right? Thoracic compliance is about 0.2 liters per centimeter of water, but total compliance is about 0.1 liters per centimeter of water. So don't worry about this little formula right here. You don't have to worry about that. Now, I said there were different types of compliance. We got dynamic compliance and we have static compliance. Basically, what you need to know is dynamic compliance is volume over peak pressure. And that's the pressure. Pressure is peak during gas flow, right? So peak pressure means when I push air into your lungs, how much pressure is it taking? If I push that volume in there, however much pressure it takes to get it there is your peak pressure, okay? If I push 500 mLs into your lungs, whatever amount of pressure it takes for me to do that, that's the peak pressure, okay? Also known as peak inspiratory pressure, PIPs, which you'll learn that a little bit more when you get to ventilators, okay? Static compliance is volume over plateau pressure. Volume over plateau pressure. Now, plateau pressure is when the breath levels off, okay? Plateau pressure will be when the breath levels off. So this will be a plateau. If I'm breathing, you're going to learn when you're looking at a waveform, you're looking at the patient take a breath in and out, right? Let me take off the stop share. Watching the patient breathe in and out, in and out, in and out, which this is called tidal volume, right? Remember I said the normal volume, in and out the lungs, breathing in, breathing out. Just like you're doing right here, you're moving tidal volume. The amount of volume you're moving is called the tidal volume, normal volume. But when I breathe in and I hold it, that's a plateau, okay? So that measures the plateau, static compliance will measure the plateau pressure, okay? How much pressure is in the lungs when I'm holding the breath, okay? I have amount of pressure when just go in to force it in and out, force it in and out, but there's another pressure called plateau pressure that measures the pressure in the lungs while I'm holding the breath. So if I push inspiratory hold there and I let it go, they'll exhale, okay? But while they're holding, it will measure that pressure in the lungs, okay? That's called plateau pressure, okay? It's the plateau pressure. Okay? So static compliance, which is CST, right? So let me write these down for you so you'll know the formula, because you need to know these formulas. You said compliance is what? C equals change in volume over change in pressure. Okay, that's compliance. And then you have static compliance equals CST equals, what does it say? Volume over plat. And then the next one is dynamic compliance. And that is C dy equals, oh, okay, volume over PIP. Those are the three compliance formulas that you need to add to your formula sheet or your whatever sheet you're going to use for your formulas in your notes. Those are the three formulas for compliance. Regular compliance is change in volume over change in pressure. Static compliance is CST equals volume over plateau pressure. And then dynamic compliance is volume over peak inspiratory pressure. All right? You'll work them out. You'll get those values from the ventilator. You're going to get the volume from the ventilator. You'll get the plateau pressure from the ventilator. And you'll get the peak inspiratory pressure from the ventilator. And they get a little bit more advanced as you go in to ventilators, okay? When you get to RT 230, Start talking about vents, okay? That's when you're going to start talking about PEEP and all of that kind of stuff. This is just the introduction. All right. Let's take a 10-minute break. It is 9:50. Come back at 10 o'clock. I'm going to pause the recording. We're going to get into what would make us see a decreased compliance or increased compliance. What diseases or what conditions would we see a decrease in compliance or an increase in compliance? Take a break. We'll start back up at 10 o'clock. All right, guys, we're back from break, and we're going to pick up where we left off, talking about compliance. We already learned that compliance measures the distendability of the lungs. If the lungs were stretched any way you want them to stretch, they have a very high compliance. If they won't do what you want them to do, they have a low compliance. We learned that the relationship between compliance and COPD are directly related. If you have COPD, you will have a higher compliant lung. We also are able to draw the conclusion that since high compliance also means a higher FRC, then naturally, if you have COPD, you will also have a high FRC, okay? We also talked about elasticity because these are kind of confusing. The COPD patient has a low elasticity, right? It doesn't stretch back. It doesn't snap back like we want it to, okay? So if I have COPD, I have a low elastance, I have a high compliance, and a high FRC because I can't get the air out. And you're going to learn the FRC component as we go on. Now, what will be some of the conditions I would see somebody with less compliant or low compliant, decreased compliant? Well, pulmonary consolidation. If there's a lot of secretions or a lot of fluid or blood or whatever is in the lungs, right? An area of tight, one of the segments are full of secretion, thick, tenacious secretions are filling up 2 or 3 segments of the lungs. That would be consolidation, right? It's a lot there. That will cause a decrease in compliance because then if I'm trying to push air in, air can't make the lung do what I want to do because stuff is there. Secretions or mucus or whatever is there, a tumor or whatever is there, right? Pulmonary edema will show a low compliance because it's full of water. The lung that's full of fluid won't do what I want it to do, right? Because air and water can't occupy the same space, all right? So it won't do what I want it to do. A pneumothorax, that's a hole in the lungs, right? A pneumothorax will be a hole in the lung. If I have a hole in my lung, no matter how much I blow, it's not going to inflate, right? It's just going to come right out of the hole. It's like saying, if you have a balloon and you take a balloon and you cut the tip off the balloon and you blow, is the balloon ever going to inflate? No, it won't do what you want it to do. It doesn't have to always be because it's hard. Just think of it, it won't do what you want it to do. So if it's a hole in the lung and I can blow, 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 it's never going to inflate because there's a hole there, okay? So that will be a low compliance. It won't do what I am trying to get it to do, okay? Abdominal distension. If you're 700 pounds and the stomach is sitting on the chest, will the lungs inflate like you want them to? No. What if you're 9 months pregnant with triplets and you land on your back? It's going to be hard to breathe, right? An increase in work and breathing. That's why it says a decreased compliance will have an increase in work of breathing. WOB is work of breathing. Okay, it's harder for you to breathe. And so abdominal distension, whether it's because of ascites, which is fluid in the peritoneal space, it can be a whole lot, almost like a gallon of fluid in the abdomen, right, that they have to drain. It could be from being very, very much overweight. It could be from pregnancy. It could also be from a tumor. You could have a massive abdominal tumor that's keeping the diaphragm from doing its job, which in turn will not let the lungs do what you're asking them to do. So that's a decrease in compliance. ARDS. ARDS is acute respiratory distress syndrome, very critical and very quickly developing condition. Will give you a decrease in FRC. So when the lung, they have pockets of lung are just closed, right? It's just pockets of closed lung and maybe secretions all over the place. diffuse, spread out, not in just one area, but all over the lung. There's pockets of closed lungs. That's ARDS, okay? Acute respiratory distress syndrome. Some people will say adult respiratory distress syndrome because we also have an infant respiratory distress syndrome, but it's mainly acute. It's something that happens just like that. Over, you know, if you aspirate a little vomit or something like that, it can travel, spread, and become very critical. Okay? That's a low or decreased compliance. Pulmonary fibrosis. Now, this is the hard part. Fibroids. You got these little hard scars over the lungs, and the lung is all scarred up, and he has these maybe like fibrosis is like scar tissue on the lung, and it's keeping it from doing what you want it to do because it's all scarred up. Okay, that's pulmonary fibrosis. Those would be cause a decrease in compliance. And then thoracic deformities. You're going to learn when we get to restrictive and obstructive diseases. Thoracic deformities would be like, say I have, well, you're going to learn pectus carinatum and all that kind of stuff. If I'm like this, if I have scoliosis, which is curved spine, and kyphosis, which is a hunchback, if I'm living like that, my lungs won't inflate like I want them to because of my deformity. Okay, some babies or people, you'll see them are all hunched over and can't stand up straight, or their spine is all twisted and curved up because of some genetic deformity. Then that will cause a decrease in compliance. Now, off to the side, I want you to write this down. Obstructive diseases. Obstructive diseases cause increase in compliance, like COPD, right? Chronic obstructive diseases. And restrictive diseases cause a low compliance. Obstructive diseases cause a high compliance, and restrictive diseases cause low compliance. When we get towards the end, we're going to do a unit about restrictive versus obstructive. What are the restrictive diseases? What are the obstructive diseases? The obstructive diseases are the ones associated with COPD. But then you're going to learn there's some restrictive diseases which cause a low compliance, and some of these are right here. What you're looking at now: pulmonary edema, thoracic deformities, pulmonary fibrosis, consolidation, abdominal distension. All of those are restrictive diseases, right? These are restrictive issues that keep the lung from doing what you want to do. If I restrict you from coming in the house, I keep you from doing what? Coming in the house. So if I have a restrictive disease, I'm restricting the lungs from inflating. Okay, so that will be a low compliance, right? Because the lungs won't do what you want them to do. Okay. All right. So that's some things we see in a low compliance. Some restrictive conditions that keep the lungs from inflating. They also make you have an increase in work of breathing. It's harder to breathe. If I'm stepping on your chest, it's harder for you to breathe, right? All right. And then there was one last one was complete airway obstruction, right? If I have you completely closed off, you're getting strangled or you choke on a chicken bone and it completely closes your airway off, right? Then it's going to be restrictive. There's nothing you can do. It won't do. You can't even get the air to the lungs, okay? We're on the next lesson, RT 210D, pulmonary mechanics. All right. Now, what are some things we're going to see for compliance to increase? All right? Compliance increases. First one is alveolar distension, floppy lung, right? The alveoli is so stretched out, right? Alveolar distension means that alveoli has just been stretched out, okay? Alveolar septal defect. If there's one of the septal wall defects and the wall of the alveoli is just messed up, okay? And then finally, obstructive diseases, COPD. Now, here they are right here on the left. You see them? Or do y'all have a space that says CBABE? Okay. The CBABE diseases. Now, these, what I'm about to tell you, are the diseases that are associated with COPD. If you have 2 or more of these diseases, you have COPD. Okay? COPD has 5 diseases that encompass COPD. You can't just say, oh, you smoke, you got COPD. You have to have 1 or 2, I think 2 or more of these 5 diseases to be considered COPD. The CBABE diseases are, and I always say, you got COPD, baby. That's how you remember it, because it's CBABE, right? C-B-A-B-E, CBABE, okay? You got COPD, baby. The C stands for cystic fibrosis. Cystic fibrosis. B for bronchitis. And it's usually chronic bronchitis, but bronchitis nonetheless. A for asthma. B, the next B is for bronchiectasis. Bronchiectasis. Did I let you in, Kayla? Bronchiectasis. And then the last E is for emphysema. Emphysema. COPD, baby. CBABE diseases. All of those are obstructive diseases. All of them. All of them are hypercapnic. The patient would be hypercapnic because they have COPD, which they have an obstruction. They can't get the air out. And what we breathe out is carbon dioxide. They can't get it out, it's building up, right? These will all cause an increase in compliance. Increase in compliance. Floppy lungs. Lungs are just like old draws. Now, number 7, that's what we talked about a little earlier. Make sure you understand this so you don't get confused. Compliance is inversely related to elastance, and elastance has an A in it. Well, I already erased it. So if I misspelled a little early, don't worry about it. Compliance is inversely related to elastance. So if I have a high compliance, that means I have a low elastance. If I have a low compliance, I have a high elastance. Elastance is how strong is the rubber band, right? How strong. So compliance is inversely related to elastance, but compliance is directly related to FRC. It's also directly related to COPD. Okay, so make sure y'all understand, because we put it on the board, make sure you totally understand the relationship between compliance, FRC, COPD, and elastance. Make sure you understand that relationship. Okay? Elastance is simply the property of resisting deformation, right? And that's fancy words for saying how strong is the band, right? How strong is the elasticity. Okay? That's very important. Compliance is inversely related to elastance. All right, then we get into resistance. How do I measure resistance? It's another formula. Resistance is RAW. R-A-W stands for resistance, equals peak inspiratory pressure minus the plateau pressure divided by the flow in liters per second. Resistance is RAW. R-A-W equals peak inspiratory pressure minus plateau pressure divided by the liters per second, the flow in liters per second. Resistance, the formula for resistance is RAW. Okay, RAW is the title of it. RAW equals PIP minus the plateau pressure divided by the flow in liters per second. All right. If I remember this, if I have an increase in resistance, I'm going to have an increase in my work of breathing. Okay. If the resistance starts getting high inside my lungs, it's going to be harder for me to breathe. Okay. It's like breathing through a regular straw, and then I give you a coffee straw. All right. The resistance inside the coffee straw is much greater than it is in a regular straw. And so how hard is it going to be for me to breathe in a coffee straw? Very high, because I increased the resistance. I went from a big straw to a little straw. And whose law says that's going to happen? Laplace. He said if you decrease the diameter, so I go from a big diameter of a straw to half of that of a coffee straw, then the resistance inside there is going to increase by 16 times, okay? Which is going to in turn have it harder for me to breathe, okay? All right, we already talked about laminar. He said laminar is smooth flow, right? Smooth flow, because that's where resistance kind of comes in. You know, it has a play with the smooth flow, okay? No. We said Laplace. It's not Laplace. It's Poiseuille. Poiseuille's law is the 16 times. Decrease the diameter by half and increase the resistance by 16 times. That's Poiseuille. Everybody say Poiseuille. Poiseuille. That's his law. Laplace talks about the raindrop, right? The surface tension of a sphere. The bigger one will suck the smaller one in. That's Laplace. That's Laplace. Huh? Yeah, go ahead. That's Laplace. And Poiseuille is the resistance one. He says if you decrease the diameter by 1/2, you increase the resistance by 16 times. That's Poiseuille, a French physicist. That's one of his laws. Okay? So if I say, what is the law of Poiseuille? What does Poiseuille say? You'll say that he says that if I decrease the diameter by half, I increase the resistance by 16 times. What if I say, what does Laplace's law say? What would you say? Surface tension. You got to, well, you have to be able to tell me. You can't say, oh, that's the raindrop. I know what you mean, but MBRC needs to know what you mean, if you know what I mean, okay? Laplace says that because of surface tension, alveoli tend to collapse, right? Smaller alveoli tend to collapse when connected with larger alveoli because of surface tension. But because of surfactant, we can defy that law, okay? Just like the bubbles you do when you blow bubbles outside. You have a big old bubble and a little bubble floating on top, touching each other and just floating together with no problem, right? Because the soapy, detergent-like phospholipid of that stuff you blow. It's just like surfactant, okay? It's the same type of thing as surfactant, okay? All right. Turbulent. Turbulent, also known as non-laminar or eddy flow. Turbulent has another name for eddy flow, okay? Eddy flow. Now, what did I say the Reynolds number was? For it to be laminar, you'd have to have a Reynolds number of what? Less than what? 2,000. So if you have a Reynolds number less than 2,000, that's laminar flow. If I have a Reynolds number greater than what? 4,000 is turbulent. And turbulent is also known as eddy flow. And all they're trying to say is the higher the flow rate, the more resistance you're going to have. Okay? If you have a water hose and it's coming on, you got it halfway cranked, it's going to come out nice and smooth, right? But if you cut it all the way up, the higher it is, the higher the resistance. And then if you cover up half the diameter, it's going to increase even more. Okay? That's all they're pretty much trying to get you to understand. All right. Don't worry about the gas density one. That's not that important. Look at number 3. Number 3 said the tracheobronchial tree that we have learned so much about has both laminar and turbulent flow caused in part by the directional changes in the conductive airway, right? Because it changes. It goes from the trachea, then turns right and left in the main stem bronchus, and then it branches off into the bronchi, bronchioles, and all of that, right? All that turning and tossing and turning causes it to be turbulent in some places and smooth in some places, okay? So the directional changes of the conductive airway. And where does the conductive airway stop? What is the last structure of the conductive airway? Terminal bronchioles. There you go. Good. The terminal bronchioles is the last conductive spot. They get off at the terminal, right? Last stop. All right. Now we are getting into the lung volumes, which is here on the board. I'm going to show you the PowerPoint for it, and then we're going to show you on the board. Because it's a really got to pay attention to how to explain. You should be doing it yourself, okay? I should see you doing your breaths, trying to figure out what is what, because there's different aspects and points of your breathing that constitute a capacity or a volume, okay? So lung volumes relate to the lung-thorax relationship, compliance and surface tension. We have 4 volumes and 4 capacities. 4 volumes and 4 capacities. So I'm going to share my screen to the PowerPoint. Lung volumes. All right, here we go. The 4 volumes are IRV, which is inspiratory reserve volume. Excuse me. ERV is expiratory reserve volume. VT is tidal volume. And RV is reserve volume. Reserve volume is also known as residual volume. You might see it either way. Those are the 4 volumes, and they have amounts that you have to know as well. So you'll have to be able to explain what inspiratory volume is, and you have to tell me how much it is. Okay? Same thing with ERV, tidal volume, and RV. So since we talked about tidal volume so much, let's describe tidal volume, VT. Tidal volume is the normal gas going in and out of the lung doing quiet breathing. That's what we say, quiet breathing or normal breathing. It's just like you're doing right now. In and out. In and out. Right? Normal movement of gas in and out of the lungs. That volume is called tidal volume. How much is that volume? How much did I say a normal tidal volume is? 500 milliliters or 0.5 liters. Okay? So you just described it. What is tidal volume? Tidal volume is the amount of gas that's moved in and out of the lungs during quiet breathing. And the amount is 0.5 liters or 500 mLs. Boom. You just did it. Perfect. And so when you're trying to think about it, you just, okay, let me look at myself. All right. And now you have to be silly. Okay. You have to be in order to get these. This right here and ABGs and pharmacology are the hardest parts of respiratory in 210. Okay. People have the damnedest times with volumes and ABGs and pharmacology, airway pharmacology. Okay. All right. IRV. IRV is the inspiratory reserve volume. Now, listen to me describe it. IRV is the amount of gas moved after a normal inhalation. IRV is the amount of gas I can inhale after a normal inhalation. Okay? So I'm going to stop the share for everybody to look at me. Look at me. He's on camera up here. This is tidal volume right here. Tidal volume, right? Normal, the gas is moved during normal in and normal out. Well, IRV is the amount of gas I can inhale after a normal or quiet inhalation. So look at me. Okay, doing tidal volume. In, out, in, out, in, and then that is IRV. The amount of gas I can inhale after a quiet inhalation. So after I go in, out, in, stop right there, and then suck as much as I can suck in, that's IRV. Just that amount is inspiratory reserve volume. Okay? Hit the light on. All right, this is it on the board. Show it to you on the board as well, so you can get a better understanding. The pistol to fall out. I want that pistol to fall out. All right. Let's see. Tidal volume. Normal in and normal out. So quiet in. This is tidal volume. DT. In, out, in, out, in, out, in, out, in. I stop and then suck in all I can suck in. This is my IRV. From here to here is my IRV, inspiratory reserve volume. Okay? It's the amount of gas that I can inhale after a quiet inhalation, right? This is in, this is out. After a quiet inhalation, I continue to inhale. That amount that I can get right there is my IRV, okay? The next volume is ERV, expiratory reserve volume. Expiratory reserve volume is simply the amount of gas that I can exhale after a quiet exhalation, okay? So normal in, normal out, normal in, normal out. Then after the normal out, I push everything I can push out. That volume there is my expiratory reserve volume. After a quiet exhalation. The amount of gas I can exhale after a quiet exhalation. That's important. The after and befores, right? Those are very important because they may make up a different volume if you're talking about the wrong thing. This is in, these are out, okay? So the amount of gas I can inhale after a normal inhalation is my IRV, right? Then the maximum amount of air I can exhale after a normal exhalation is my ERV, okay? But guess what? No matter how much I push out, it's always going to be some air left in my lungs, and that is residual volume. I cannot access that no matter what. I can never access the residual RV. That's the amount of air left in the lungs after a forceful exhalation. So I can blow until I'm blue in the face. It's always going to be some volume still left in my lungs. That is my residual volume. Now, I can't exhale that. I mean, I can't access that, but it can be knocked out of you. You ever fell down and knock the air out of you? You knocked out the RV. When you hit yourself up on your stomach or back, and then finally get it back, that's because you knocked the wind out of you. That's what they mean. You got down into that RV. Okay, the lungs almost touched. Okay? And so when that happens, you have to build it up really quickly, right quick, and then you're going back to business. I remember I built a ramp for my Sigma Decade when I was young. And we hit the ramp, and I fell straight on my back. Knocked all my hair out of my lungs. I'll never forget that. All right. Those are my 4 volumes. Tidal volume, inspiratory reserve volume, expiratory reserve volume, and residual volume. Okay? I just told you where they are. I explained it to you, right? You have to be able to do that. Tidal volume, normal in, out, in, out, in, out, in, out. Normal in, keep on going, that's IRV. Normal out, keep on going, that's ERV. Okay? Now, then we have 4 capacities. 4 capacities. Yeah, yes, ma'am. Yes, ma'am. I'm gonna give them to you. Let's master this part first. Well, here they are right here for your thing. Tidal volume is 0.5 liters or 500 milliliters. Inspiratory reserve volume is 3.1 liters or 3,100 milliliters. Expiratory reserve volume, or ERV, is 1.2 liters or 1,200 milliliters. And reserve volume is also 1.2 liters or 1,200 milliliters. Okay? This is what I got on the board right here, the spirogram. You can go to YouTube and watch all kind of spirograms. I'm going on about it. I already have this on the board. All right, inspiratory, and this kind of just goes into it. What I just said, I'll go through these slides and you can go back and kind of study them a little more. But inspiratory reserve volume is maximum inhalation following a quiet inhalation. See that? Written in words for you. Inspiratory reserve volume is the maximum amount of air I can get in after a quiet inhalation. Quiet and normal mean the same thing, guys. If they say normal inhalation or quiet inhalation, that's the same thing, okay? Normal, 3.1 liters. Tidal volume, the volume moved during quiet breathing, in and out. Normal, 0.5 liters or 500 milliliters. DT. Expiratory reserve volume, the maximum amount of air I can push out following a quiet exhalation. Like I said, it's very important to know where is it starting, because there's a different amount when I say the amount of air I can push out after a quiet inhalation, okay? Because you're going to start adding volumes together, okay? And that's when we come to capacities. I think it's one more of these right here. Reserve volume, the gas remaining in the lungs after a a maximum exhalation. After I push all the air I can push out, there's still air left in my lungs, and that's called residual or reserve volume. Now, that leads us to capacities. And capacities are 2 or more volumes or capacities added together. Capacities are 2 or more volumes or capacities added together. So when I start adding volumes together, now I'm into my capacity, my ability of my lungs. I have an inspiratory ability and stuff like that, okay? All right. Capacities, like it says, consist of 2 or more volumes or capacities. Here they are. Excuse me, I'm gonna use the restroom right quick. Lung capacities, and look at those right quick, and then look at them on here to see if we can figure out what plus what equals what. And I'll be right back, because there's gonna be some mathematical questions that I'm gonna ask you. Damn, I should have paused, but I didn't. All right, volumes and capacities. Inspiratory capacity is IC. Vital capacity is VC. FRC is your functional residual capacity. And TLC is your total lung capacity. All right? So, look up here. My capacity to inhale is my inspiratory capacity. That consists, now what does this block here consist of? Huh? Good. So IC equals IRV plus VT. What about my functional residual capacity? What does it encompass? ERV and RV. So ERV plus RV equals FRC. What about my vital capacity? Vital capacity is what? IRV, tidal volume, and ERV. Good, because we cannot access the what? Can't access that. So my vital capacity is everything you can do, Ms. Rose. Everything you can do. Take a deep breath in so you can't do no more. Go. All the way, all the way, all the way out. Now blow it out, blow it out. Blow, blow, blow. All the way, 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 all the way. That's vital capacity. Vital capacity is everything you can do. Now that's how it's going to sound in the hospital at the PFT lab. Pulmonary testing, PFT, pulmonary functional testing. Okay, pulmonary function test, and they're gonna say, okay, Mr. Johnson, breathe in, breathe in, breathe in, blow, 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 keep going, keep going, keep going, keep going. He's gonna be blue in the face, right? But it's gonna be on the computer. It's gonna be squiggling, squiggling, squiggling. It's measuring his different volumes and capacities. Okay, and it might say, okay, take deep breath in, then in and out, in and out, in and out. He can puffing, right? Those are different tests. Good job to have if you like doing that. You'll be at the hospital in your own office with the body box where they come in and close the door and sit in it. It's got computers. You work Monday through Friday. You set your appointments. You call your patients. The pulmonologist will say, I want pulmonary function tests on all my patients. You'll call them, set up an appointment in your appointment book, go into your office, and they'll come and you do a pulmonary function study, print it out, send it to the chart, Monday through Friday. You don't even see patients in the hospital. You only see people who come in to do a PFT. But that's very important because PFTs is the gold standard of treating COPD. I can only treat COPD unless I have a good pulmonary function test first, so I know where to start, right? It's like teaching math. I need to know where I'm at first. I do a little pre-test to see where I am, right? And so that's what PFT technologist does. RRT can be that. That's what you are. You're going to get all the training you need for that in this program. You can go into that. You can go into just peds. You can go into adults, whatever you want to do. Home, teaching, whatever. Okay? But that's what that's why I'm not being funny when I'm saying go, 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 because that's what you're going to be used to. Okay? You're going to be hearing that at the hospital. So the vital capacity is everything you can do. So that means my normal in and out, everything I can suck in, and everything I can push out. See that? So from here to here is vital capacity. See? From here to here is everything I can do. Vital capacity. So I can say IRV plus VT plus ERV, or I can say TLC minus RV. See that? TLC, which is everything, minus RV leaves me with VC. Okay. All right. And then so TLC again is your total lung capacity. That's everything in your lungs. Okay. The capacity of all the volumes in your lungs. So TLC is IRV plus VT plus ERV plus RV, or IC plus FRC. See that? Or BC plus RV, right? TLC equals all of that. Several different ways I can show that mathematically. Okay? TLC, which is all of it, is IRV plus VT plus ERV plus RV, or vital capacity plus RV, or inspiratory capacity plus functional residual capacity. Okay? So why do we have so important on FRC? The FRC is the most important one of all of it. That's your functional residual capacity. So FRC is the amount of gas in the lungs following a what? Look at it. FRC is right here and down. FRC is all of the gas left in your lungs after a quiet exhalation, or normal exhalation. So after I let out, what's left in my lungs is FRC. If I was to keep pushing, I push down into the ERV, right? So just in and then out, everything left down there is FRC. That's why it's so important. That's why a COPD patient's FRC is larger than yours, because we in and out. We push out a normal amount. But when they in and out, they can't get the air out. So their FRC, the amount left in their lungs is greater than yours, because they can't get it out. See that? So COPD equals a higher FRC. Okay? It also equals a higher compliance, because the lungs are floppy and they won't do what you want them to do. Okay? I mean, they'll do what you want them to do, but they won't exhale. Okay? Can't get the air out.
RV, you said we can't access it. So is there a way that they or a test or something they do?
Yeah, a pulmonary function test. All right, so here it is right here, just kind of showing you some of the values. Now, inspiratory capacity, which is IC, is 3.6 liters or 3,600 milliliters. You can figure out different ways to help you remember this stuff. It's cool with me. I had a student in my very first class that said, "Oh, I got a way to remember IC, Mr. McCarthy." She was talking about, she was at the club and IC 3-6 Mafia. And that helped her. IC 3-6, right? So that helps her. Inspiratory capacity is 3.6 liters. That helps you, not whatever you want to use is fine. Okay? Whatever kind of mnemonic you want to use. But inspiratory capacity is 3.6 liters. Functional residual capacity, FRC, is 2.4 liters. And it makes sense because ERV is 1.2 and RV is 1.2. When you add them together, it's 2.4. Right? Remember what it said? In the volumes, we said ERV is 1.2 liters, RV is 1.2 liters. Well, if FRC is ERV plus RV, then 1.2 and 1.2 is 2.4. So FRC is 2.4. FRC, 2.4 liters. Inspiratory capacity is 3.6 liters. Right? Vital capacity is everything you can do. See that? Inspiratory reserve volume, tidal volume, expiratory reserve volume. Everything that you can do is vital capacity. And that is 4.8 liters. 4.8 liters. And then finally, total lung capacity. The total amount of air in your lungs completely is 6,000 milliliters or 6 liters. 6.0 liters. Use my brown to put the brown in there. All right, so we said ERV was 1.2. RV was 1.2. Tidal volume was 0.5 liters, right? IRV, what was that? 4.8? No, 3.1. Okay. 3.1 liters. Okay. And well, RV is 1.8. All right. That's your spirogram, guys. That's the spirogram. Here's a picture over here. Like I said, this PowerPoint is on the in the module, so it's welcome to it at any time. But this is what I have rolled on the board pretty much. It might be backwards, but that's it. I think that's right. I think it's a little bit different, but it's the same stuff. Okay? Same stuff. You must memorize this spirogram. Now, the good news is when you take this test, when you're sitting here, I'll give you a blank piece of paper and you can write whatever you want to write on it. Okay, after you have cleared your desk. So you here, at your computer open, everything is clear, I'll pass out a scrap piece of paper so you can write the formulas that's on your mind. Go ahead and write the formulas, linear ventilation, compliance, draw the spirogram, right? It should be easy to draw the spirogram. I usually draw the spirogram without the waveform, just this part. Just this part, okay? And so it makes it easy. If you do it like this, it makes it easy. You draw the spirogram, learn how to memorize drawing, right? You need to know them volumes and stuff in your head, but you need to know how to write it right quick. And it's simple, just like this. Make a big box. Right here. All right, so let me stop the share. Quick way to draw the spirogram, which you are able to do when you come to campus, when you take the test, I'll let you draw the spirogram once you have cleared your desk on test day. So memorizing is key, okay? All right, so you can simply make a box. All right? Then make a long box here for TLC, TLC. Then I like to go in the middle. The middle is tidal volume. Tidal volume in the middle. What's above tidal volume? The amount of air I can inhale after tidal volume is what? IRV. Then the amount of air I can move after tidal volume is what? ERV. And what's always left? RV. Got that so far? Now, VT plus IRV is what? Now, I mean, what is the capacity? IC, inspiratory capacity. And then these two down here are what? ERV and RV make up the FRC. FRC. And then I can always make a little dotted line. RV always is there. So what is this? Everything that you can do. DC. That's the spirogram. Just memorize the spirogram. You should have no problem. Then, because then you can have that. And if I say, well, what is, so we'll do it together. So looking at the spirogram, you learn how to do it. And I said, okay, Ms. Scott, what is VC plus RV? VC plus RV equals what? See, all of it. VC plus RV equals what? You're looking, I'm not looking for numbers. I'm just looking for the section. This plus this. So it's all of it. TLC. TLC. What about Mr. Rivers? If I say inspiratory capacity minus tidal volume equals what? IC take away the VT leaves me with what? Look right here. Inspiratory capacity is these two, right? This is inspiratory capacity. Inspiratory capacity minus the tidal volume leaves me with what? IRV. Yeah, because this is, these two equal IC, right? And these two equal FRC. What if I said, Ms. Rose, FRC minus ERV leaves me with what? RV. Miss Woods, what if I said ERV plus RV equal what? FRC. Miss Renfro, if I said IRV plus VT plus ERV plus RV equals what? TLC. What if I say, Mr. Rivers, TLC minus the RV leaves me with what? TLC, take away the RV, leaves me with what? Look right here. Total lung capacity, take away the RV. What's left? What's the biggest box left? BC. You got it. BC. All right, so that's how you have to look at it. Okay, what if, Mr. Rivers, what if I said, what is IC plus FRC? All of it. IC plus FRC is what? TLC. Okay, that's it. Now, of course, once you learn this, then go back and start remembering the numbers, okay, the amounts. But you need to know this down pat first. And there's several ways you can do it. I think when I was in school, I even made a circle one. I don't know what I did. But TLC was all of it. Then I had a little box, I had, get creative with it. But as long as you got the fundamentals of it, you're good. But this is the spirogram. These are the 4 volumes and 4 capacities of your lungs. Okay? Now, you need to know how to do this and how to move through it to know what's what. But you also need to be able to explain it to me, right? So sometimes when you do this, because you can make colors. If I was you, I would do the VC one color, what you call it, different colors. So then, like if I say VC is going to be blue, well, then I will have another little line, right? Because all of that is VC, right? This is all VC, right? And then if I say I'm going to do IC green, all right? And if I say I'm going to make my IC green, then I put IC in green, and then do this. See that? IC. So FRC, I want to do it another color, just whatever color the letter is, and then the whole encompasses all the thing that's in the green is IC. Everything that's in the blue is VC. See that? So you can get, special and do it like that to help you understand it. Okay? Because you will have a homework that will ask for these in additions. TLC minus RV equals what? You gotta say, oh, that's VC, right? If I say, okay, IRV plus VT equals IC, or IC minus IRV leaves me with VT. Okay. Now, don't try to overlook into it. Just do the box, look at it at home, and kind of start doing it on your own. See if you can do it without looking, and compare yourself to the video. Okay. Once you got it, you got it. It's like tying your shoes. You'll never forget how to draw this. And then, like I said, when test day, you can draw it on your paper, and when you see a question about it, you relate to your paper. It helps you get that problem. You know what I'm saying? Makes it easier for you to do it instead of trying to remember it on top of your head and you don't have nothing in front of you. But see, that wouldn't be cheating because it's coming from your head. Your desk is clear, right? Everything coming straight from your head. All right, moving right along. All right, have a good day. See what's after that. Okay, that's the spirogram. All right. So this is kind of the PowerPoint goes on to kind of help break it down, saying that IRV plus VT equals IC, right? in which the inspiratory capacity is the maximum inhalation following a quiet exhalation, and the normal is 3.6 liters. So it kind of gives you everything together. How you explain it in sentence form, how you do it in mathematical form, and the amount. Okay, this is very good. That's inspiratory capacity. Then functional residual capacity, the FRC, bless you. FRC is ERV plus RV equals FRC, right? And that is the gas in the lungs following a quiet exhalation. Everything that's left after a quiet exhalation, not a forced. What is left after a forced exhalation? RV. After you done pushed everything you can push out, RV is always left. But gas in the amount of gas left in the lungs after a quiet exhalation would be FRC. Okay. Vital capacity, IRV plus VT plus ERV equals vital capacity. And the vital capacity is maximum exhalation following a maximum inspiration. Everything that you can do. Maximum amount you can blow out after a maximum that you inhale, right? That is your vital capacity. Normal, 4.8 liters. Total lung capacity is IRV plus VT plus ERV plus RV. That is the TLC. That's everything, period. Okay? The gas in the lungs following a maximum inhalation. So after I inhale as much as I can inhale, then all of the gas that's in my lungs right now is total lung capacity. That's everything. RV, vital capacity, everything. Okay? Everything in my lungs. And the normal is 6 liters. 6 liters. All right, so they say FRC is why it's so important. FRC and lung compliance. FRC is the most consistent volume diaphragm at rest. When the diaphragm is at rest, that's your FRC, right? A quiet exhalation, your diaphragm is now at rest. Also, the at FRC, you have an equalization of opposing forces, right? The pulmonary and the thoracic cavity are equal. They're not making you inhale, not making you exhale. Those forces are now even or equal. Also, as elasticity changes, the FRC will change, okay? That's why I showed you that. Make sure you're able to put those relationships together. So for instance, let's look at it. If my elasticity decreases, what happened to my FRC? Increase. Good. If my elasticity gets weaker, right? The elastic is just weaker. Well, my FRC is going to increase because I can't get all of it out because doesn't have any elastance. If my elasticity increases, my lungs become more elastic, then my FRC is going to do what? Decrease, right? What about the last one? At FRC, intrapleural pressure is normal, about -5 centimeters of water. So that's just showing you that it's equal, right? Your opposing forces, because we said all of this, guys, is opposing forces. The force of your pleural pressure and your thoracic pressure, right? Trying to oppose. The lungs want to deflate and the chest wants to inflate, okay? But because of the two opposing forces and the pleural space, they're holding you open, and that's how you have your shape and your form. Now, when I take a deep breath in, my diaphragm descends or flattens, triggered by the phrenic nerve, right? And that will cause my intrapulmonary pressure to become lower than the ambient pressure, which will then make air go in, because air travels the path of least resistance, okay? So at FRC, it's equal. I'm not sucking in, I'm not blowing out. I'm equal, okay? That's why it's so important. At FRC, the intrapulmonary pressure equals ambient pressure. There it is. The pressure inside my lungs is the same as it is outside. And that's why no air is moving in or out, because they're equal. Understand that? The pressure outside and the pressure in my lungs are the same. Therefore, there's no movement of gas. There's nowhere to run. Why is it going to run if it's nothing small? Caleb, we have cupcakes if you want one. And the sanitizer's there and napkins on the other side. All right. Now, with an increase in compliance, which is a decrease in elasticity, an increase in ease of inspiration, but difficulty in expiring, also known as floppy lungs. If I have a high compliance, I can suck in real easy. I can take a breath in till the cows come home. But the problem is I can't get it all out because I have a lower elasticity, right? It's harder for me to blow it out. I can get it in, but I can't get it out. That's an obstruction. Obstructive diseases cannot get the air out. Therefore, they are always hyper what? Capnic. Thank you. Because they are retaining what? What gas? CO2. Got it? All right. If I have a decrease in compliance, then I have a decrease in the ease of inspiration, and that's also known as stiff lung. If my compliance is low, then that means I have a high elastance, right? And I'm trying to inhale, and it's tight. It's like you remember, think about the broccoli. You ever bought broccoli in the grocery store? And how broccoli has that big green rubber band on it that's real hard. It's like, damn, if I could flip somebody with that, it'll go through them. You know what I'm saying? It's a real hard, that has a high elastance, right? Now think of that rubber band and some old drawers, the band inside some old drawers, right? They don't flick at all. They just hang open, right? Or an old rubber band, right? A real old rubber band or scrunchie that you had on your head since middle school, right? It's lost all of its elastance, okay? So those are the difference. High compliance would be the floppy drawers, right? The band that's real flimsy. And low compliance would be the rubber band on the broccoli, okay? Real stiff. So if it's stiff, it's hard for me to get the air in, right? All right. Almost done for today. Okay, FRC. See how we're talking about FRC, guys? Make sure you do your reading for this section. Study these notes because FRC and these spirograms are so important. FRC is directly impacted by the compliance. We know that because if it's indirectly mean they go the same way, right? Compliance go up, FRC go up. Compliance go down, FRC goes down. They are directly related. Decreased compliance means stiff lungs. Increased compliance means a decreased elasticity or floppy lungs, right? Emphysema, which is one of the COPD diseases, the C baby diseases, right? Is also known as floppy lung. Think about the back of your elbow. You know how floppy that is right there, that little meat on the back of your elbow when you stiff your arm out, how almost like a scrotum, right? That's how the lungs are for COPD. They're just kind of like a scrotum, okay? Or the back of your elbow, that meat on the back of it is just kind of there, right? That's how it is. If the lungs are stiff, the alveoli are harder to inflate. If the alveoli are not inflated, FRC is decreased, okay? And what can we do? What can we do? Well, there's many things you're going to learn that we can do to treat COPD, right? Or treat the restrictive diseases that are causing the problem. Like I say, we get a little farther down the line, you're going to learn about this restrictive diseases versus obstructive diseases, okay? All right, so at this point, guys, we're going to stop right here. I'm going to show you what the homework is for tonight. I'll have to look at it. I'll let you know. Probably not, but I'll let you know. I'll look at it tonight and send y'all an email about when the next test is. So we got to get it in. We can't stay behind this because I gave you an extra day. We got to get on going. Okay, we can't be a day behind through the rest of the thing. Okay, but this is the homework. Can y'all see my screen? Okay. Let me share my screen. Spirogram quiz is for the homework tonight. It's in your should be in the module, but I'm going to set it up to where you see that it is homework that's due 10/26 20. That's not for attendance because attendance was for your test. You took the test, you got attendance for the day. But this is part of the homework. So make sure you do it, okay? It's going to say, it says calculate which volume or capacity is being referred to. Not the numeric value. I don't want numbers. I want the section, okay? So like number 1, TLC minus the RV is what? VC, vital capacity, right? TLC, which is all of it, take away the RV, leaves me with what? VC. So that's what you would do. Number 1, you would put VC, okay? So that is the homework that I'm going to let you submit tonight for your homework. I'm going to put it in there right now, all right? When you come back tomorrow, we will get more into it and try to finish up this lesson. But you have to study. You have to study and make sure that you guys are reading the material, and it shouldn't be a problem, okay? We got to get into alveolar minute ventilations and all that tomorrow, so try to be live or here as much as you can tomorrow to get the benefit out of it, okay? Again, I don't know. I will give you an email tonight about when this test will be done so you can make your arrangements to be here. But it won't be, I'm off, you know, we got an extra day on the last one, so all of the tests are now, we're all off the rest of the syllabus. I can't do that. We have to pick it up and double up whatever we have to do. Only reason I did that is because it didn't record. For some reason, that video for the 21st did not record, so I gave you an extra day, okay? But I can't do that anymore. Even if it doesn't record, it's not a guarantee, again, to be recorded, okay? You are responsible for the material. Just like if you came to school and you were absent on Tuesday, come back Wednesday, you have to get the notes from somebody or, you know, whatever you got to do. But I can't say, okay, let me teach you Tuesday again. I can't do that, okay? So it's not guaranteed. It's a pleasure for you, and it's a benefit, but it's not guaranteed because anything could happen. I would never depend on technology for my education because anything can happen. My computer could freeze up. You can lose the signal, Wi-Fi go down, whatever, and I can't even Zoom, right? So that is always a possibility. All right, so have a good day. I will put the homework assignment in there as well as send you an email a little later about the test, okay? Good job today. We had a way better average today on the exams. It's going to start getting a little more difficult, but you got it. We still got plenty of time. There's nobody is out for the count yet, okay? Have a good day. I'll see you guys tomorrow.